We're going to talk a little bit about knowledge translation today, a topic that's kind of near and dear to my heart. It's going to be about like 15 minutes, and then there'll be a couple minutes at the end we can kind of talk through a little bit. I just want to be grateful for SAEM for inviting me to present here again this year, and really grateful for all you kind of getting up early to come see this lecture. I mentioned this during one of my talks yesterday that I read a book recently. It's called Steal Like an Artist, and I really kind of feel like some of the best docs in our profession are actually really good thieves, and I'm kind of one of them. I kind of totally actually advocate for stealing. A lot of the knowledge that's going to be in this talk here right now I've totally lifted from other people, like my former program director in residency, my current program director, even a lot of my residents. We're constantly surrounded by really smart and enlightened individuals, and I think it's up to us to kind of trying to carry their message forward. So hopefully you'll see some of that in my slides over here. And so 17 years is the average time it takes from medical research to reach clinical practice. You'll see on some of my slides here today, there are these QR codes at the bottom. If you totally want these articles, you can take out your phone and you can take out your camera, and if you put your camera and focus it onto the screen over here, it'll pop over and you'll see a little light that'll kind of light up, and it'll actually send the article to your phone if you're that into it. If you're not that into it, you can kind of send me a tweet or talk to me afterwards. I've got hard copies here, and I can also show you the notes as well. But this was kind of a cool article. It's a couple years ago. It was a couple of folks got together and they did a big lit search. They looked at 23 articles that were published and then looked at the time lag, and they quantified the time lag from when those articles were published in the journals to when they were actually implemented in actual clinical practice. And some it took like 8 years, some it took 30 years, and they kind of averaged them out to about 17 years. So hopefully we're not practicing in 2001 right now. Hopefully nobody's using SCVO2 monitors for early goal-directed therapy, but it's something to kind of think about in terms of why these time lags are out there and what we can do to try to kind of chip away at that a little bit. I'm going to do 3 parts to this talk. The first is going to talk a little bit about the history of KT. I'm going to talk about kind of like a cycle and a way that you can kind of implement KT into your own practice. And I'm also going to include a little bit of a KT initiative that we're doing at our shop at Hackensack. So this is basically what I look like throughout medical school, kind of like just a little unhappy and kind of just frustrated and pretty worked. And part of the big challenge that I had was initially noticing as a medical student just a wide spectrum of practice variability, right? I mean, we all know it, you know, and that goes from lots of different things. There's practice variability in terms of imaging, right? I'll work with a doc, and this doc will get an x-ray for a patient who comes in with lower back pain, and other docs won't. I'll work with a different doc, and she'll get an ultrasound of a patient with renal colic, and a different doc will get a CT. It's imaging. It also means in terms of treatment as well. You'll work with docs, and some will give antibiotics for pharyngitis, and some won't. Some will give steroids for pharyngitis, and some won't. And as a medical student, it became kind of challenging to think about, well, what am I going to do when I graduate and I go into residency? What's my practice going to look like? And so I went into residency and still kind of started as a resident, and then the same thing happened. I worked with my attendings in the emergency department in Detroit, and everyone had a little bit of different flair. And so my program director noticed that I was kind of frustrated by it, and I was kind of trying to figure out what's the best practice here. And so she made that a point of my journal club. And so my journal club during my first year was on ACS and how providers manage patients who come into the emergency department that they're worried about having acute coronary syndrome. And so I was psyched because honestly, as a resident, I was always kind of baffled by that. Some docs got 1 troponin, some docs got 2 troponins, some docs admitted everyone, some docs let everyone else go. What was it? What was the key to it? How did docs risk stratify folks? So I did my homework. I looked at, it was the first time I'd ever been introduced to things like ACEP clinical policies. There was one on ACS, and so we used that along with some journal articles, and we had a nice dinner, we had some wine, we had a bunch of, my program director was there, my APD was there, a bunch of attendings, a lot of residents, and it became really clear that everyone was doing something a little different, maybe a little different from what the literature was saying, a little different from what the clinical policies were saying. And so it was kind of like, okay, no, we're kind of on the same page, that we're a little bit different. And then I went back to work the next couple of days. And honestly, I felt like I actually noticed a change. I felt like not so much maybe in everybody, but definitely in myself. I was a little bit more thoughtful about how I incorporated that literature and those guidelines into my own clinical practice. So I kind of got psyched about it, and instead of kind of freaking out, I actually got pretty hopeful. Once I graduated, I ended up doing a fellowship in knowledge translation at the New York Academy of Medicine, and now I get to kind of train future knowledge translators at Hackensack, the majority of them who are upstairs right now in the Sano Games. So a little bit about a history of KT. I thought this was kind of interesting. So this is the British Royal Navy and the 100-year war against France. Who knew that Britain and France fought for 100 years? Hundreds of thousands of sailors kind of engulfed in this pretty brutal battle for 100 years. And the majority of them didn't die from bullet wounds or cannons or even drowning. The majority died from scurvy. And they couldn't figure it out. They couldn't figure out what was going on with these sailors. These sailors would get on board these boats, and after about 2 weeks, when they run out of kind of fresh produce, their body starts falling apart. They start getting these lesions all over their body. Their mandible loosens up and their teeth start coming out. They start to have internal bleeding because the collagen fibers in their bodies are starting to kind of leak a little bit of blood, and they'll end up having internal bleeding in their lungs and in their brains and dying. And this went on, and they couldn't figure it out. And then someone tried to figure it out. This is Dr. James Lynn. He was a Scottish physician. He was on board one of the ships in the Royal Navy. And he's like, you know, we've got to get to the bottom of this. And so he's like, I'm going to conduct this experiment. Now, this is granted, this is like 1784, so this is a long time ago. But basically, he conducted one of the first ever like randomized clinical trials on board this ship. He basically took 12 sailors and paired them up. And one pair he gave sulfuric acid to drink every day. The other pair he gave seawater every day. And one of the lucky pairs actually got some limes, okay? And no surprise, 2 weeks later, the folks who got the limes fared much better than those with the sulfuric acid. He was pretty psyched about his findings. It was a really small sample size, right? Kind of 12. But he went ahead and he published it. And the interesting thing is that when he published it, he put a small paragraph in, not only saying that he had found the cure for scurvy, but that he had developed an extract that you could buy, and he advertised that extract. Well, the way that he made the extract was basically he took all this lime juice and he boiled it and made it into this kind of little fine powder, and then sold that extract to other individuals. The problem is that when you boil lime juice, you basically boil away all the vitamin C, and so it didn't work. So he came up with this experiment. He figured out the way to do it, but because he tried to make a buck off of it, it got shelved, and it took another 200 years before people figured out the relationship between vitamin C and scurvy. So it's not 200 years, but it's still 17 years. So the next part of the talk is talking about now how hopefully we all can kind of take something from this kind of back with us and maybe start to create like a KT initiative of our own. This is the bridge basically going between like evidence and practice. I try to think about like how we can start to cut into that 17 years. And I thought about it this morning, and I actually thought, well, actually we're already doing that. But the fact that you're here today is starting to kind of cut into that 17-year gap, right? There's a reason that we're not using SCVO2 monitors anymore for early goal-directed therapy. And it's because you guys have read Process and Arise. It's because you guys have seen abstracts and posters presented at SAEM. So that's kind of where we're headed. This is another link. The article is down here as well, that QR code. And this is kind of like the knowledge translation cycle here. And so this was put out by Graham about 10 years ago, and it's kind of a go-to in terms of, at least for me, trying to set up a KT initiative. I'm going to use this cycle for the rest of the talk and kind of talk you through an actual KT initiative that we're doing at the Hackensack University Medical Center. You'll notice like in the center is the knowledge creation piece, and then on the periphery are some of the other like elements that we're going to talk through. I like the way it's set up because I feel like as you go through a KT initiative at your institution, you're constantly going to have to keep kind of like, going back to the well of knowledge. And the fact that they put that knowledge creation piece in there, I think is really vital as you see as we go through this initiative. So the first part at the bottom here is identifying a problem and trying to figure out like what's your problem going to be. So for me, I try to look for things that are going to be kind of clinically useful, and as you all do. And so I thought one of my first years as an attending at a residency, I started a new program at Hackensack, and I got a 22-year-old kid who comes in with abdominal pain. He's got no past medical history. His vital signs are stable. I do an exam, and he's got exquisite tenderness over his right lower quadrant, right? We're all kind of know what we're thinking at this point. What's the next step? Well, the next step is oral contrast. This poor kid who's like nauseous and feel like he's going to vomit needs to get a CAT scan, right, to see whether or not he's got an acute API, right? Maybe at some institutions you can call surgery and they'll come down without the CAT scan, but not at my institution. And at my institution, they want a CT. And they think about that oral contrast. And I thought, man, this is the last thing I would ever want to have to do, is to have to drink a liter of kind of pretty gross stuff right before I have to get a CT. And then the thought of, well, if I have to go up to the OR, they're supposed to be NPO, and yet I just pounded a whole thing of fluid. So I was kind of a little challenged by it. I wondered if it was actually necessary. I knew when I trained in Detroit, that wasn't necessary. A lot of times I didn't have to give oral contrast for patients that I had a high suspicion of intra-abdominal badness. But this is how it was at my institution, and I get it. And actually, it's a lot of places it's like this. So I started to kind of think about like what type of, that was going to be my project, was like how I can figure out whether or not you need to obtain oral contrast for undifferentiated abdominal pain. And so this is another link to this Figueroa research questions. This is a really great topic here. We use this for our emergency medicine core faculty. So we're in the process of training all of our core faculty right now to become research preceptors, basically trying to teach them how to lead our residents. And so in order to do that, they need to figure out, well, how do you come up with a hypothesis? How do you come up with objectives? How do you submit something to the IRB? How do you bring it to publication? This is actually a really nice article that's here in the links. It'll also be in the show notes as part of this talk. So my problem was essentially like whether or not you actually needed to use oral contrast for undifferentiated abdominal pain. We're going to create an intervention where we create a prospective randomized clinical trial. Half of the patients got oral contrast, half of them didn't. That was going to be our comparison, and we're going to look at outcomes to see what happens. So we start with oral contrast. For knowledge creation, for me, it's research. It's kind of looking at PubMed, looking at seeing like what is out there right now. A lot of the research on intra-abdominal stuff comes from surgery. And there's actually a ton of really good studies that show that you do not need oral contrast for suspected appendicitis. There's not some good stuff in terms of gastritis. There's not good stuff in terms of diverticulitis. And I wanted to look at all intra-abdominal badness, undifferentiated abdominal pain. And so did a lot of research, and we did our homework. This is the next article that I have up here is kind of how to conduct a systemic review. When I first kind of ran into this as a fellow in KT, I was pretty overwhelmed by it. I'd never conducted a systemic review before. It felt a little overwhelming to me. But it's actually not that hard, okay? And I try to break it down into just a couple of components. The first is talking to your colleagues. And this is simple. Just talk to your dudes. Talk to the folks that you work with. Talk to your program director, your chair. Talk to folks outside of your specialty. Specifically for something like this, this wasn't just an ER doc issue. This involved radiologists, gastroenterologists, surgeons. See what their preferences are. See how they practice. So I started to do that. I talked to a lot of folks. I actually got a lot of real interest from radiologists who also believed that this was not always necessary to do this. Look at your institutional policies. I'm sure that your institution that you practice at has a policy specifically at least for something like this. We did at our shop. Patients who came in with undifferentiated abdominal pain, the expectation was to get a CAT scan with oral contrast, NIV contrast. And so try to figure out whether or not that was up with the times and whether or not we could change that. We did our homework. We did some clinical research. It turns out, I've read a couple of really good articles that say when you drink that oral contrast, it reaches the appendix 30% of the time. That's 70% of the patients who drink that oral contrast, it's not even getting to their appendix to light that up. So is it absolutely necessary? We looked at the guidelines, and actually I was really surprised. There are FACEP policies. There are also American College of Radiology policies that talk about limiting oral contrast for undifferentiated abdominal pain. So we found that information, and we also then went on the internet. All right, I'm totally tell you guys that I did go on Twitter. I took a poll. I wanted to see what other providers were doing out there in the world. And it turns out like a lot of folks were trying to figure out the same thing I was. The next part is adapting the knowledge to the local content, and this is where you really kind of have to identify other stakeholders at your institution. At our shop, it was really looking at surgeons, GI docs, speaking to residents from both specialties, speaking to radiologists, and getting them on board really early with any type of initiative you want to do. The last thing you want to do is to try to kind of just ram something down the throat of radiology and they're not cool with it, or of surgery. We're all kind of in this together. We all want what's best for our patients. So to kind of get them on board early was really important. When we started to write up this study, the co-authors on the study represent a wide spectrum. They're not just ER docs, but they're also radiologists on our study as well. Barriers to knowledge. So this is a big place, right? Anytime you're going to start any type of KT initiative, there are going to be things that are going to be in place that are going to kind of stand in the way. And sometimes they're institution specific. These are four of the ones that I feel like are the biggest issue. One is the lack of knowledge. Folks have just been kind of practicing this way, and that's the way that they've been doing it for 5, 10, 15, 20 years. It's kind of hard to change folks. So we had educational sessions. We did it with our nurses. We did it with our residents. We did it with our attendings. There's also perception mismatch, right? You know, raise your hand if you think that we get too many CTs for patients who come in with PE, right? Raise your hand if you get too many CTs, right? So that's honest. I like that. But there's a mismatch. There's a belief that there's a problem, but maybe we're not the cause of it. All right, so kind of what we did with that was we kind of did a little bit of audits, and as we went through this, this study, I was able to see which providers were actually ordering oral contrast and which ones weren't. We tried to really streamline our initiative. Anytime you make a project that's just way too big and complicated, it's probably not going to be accepted, and so we tried to make it really simple. So we created, like, our study basically had two arms. You either got oral contrast or you didn't. It was randomized as simple as possible, days of the month. Odd days, we did the odd thing. You didn't get the oral contrast. Even days, you did standard of care. You got the oral contrast. It was simple. And then there's the lack of belief, right? Who's going to believe Zodda, this like kind of junior attending, like fresh out of residency? But they'll believe my program director. They'll believe my chair. They'll believe the chair of radiology when they bring it up at GME meetings. So I got them on board, and they became the voice for this project. We designed a study, and that was another big part too. So this is another article that we kind of shared with our preceptors, our core faculty at Hackensack. This again is another really kind of good article that kind of helps you through the process of coming up with a hypothesis, laying out objectives, and how to submit to the IRB. We continued education because we noticed that once we started this initiative, it stalls. You know, and at the very interest, people like get pretty excited about it, but then people lose interest. There are other things that happen. Overcrowding happens. Flu season happens. So it took a lot to kind of continue to keep this project going. And so that's where you need to kind of be like really kind of champion at these meetings, and as well with your peers to do it. The nice thing, and I'm not sure, this might not be the case with everyone here in the room, but if you have residents in your program, they can really be champions of this initiative. So actually, one of my residents who's actually in the room right now is a champion of this initiative. She's going to actually be presenting this at an oral abstract later on today. So I don't want to steal too much of her thunder. So present your data, that's where, so you go through this whole process, you come up with this initiative, you identify stakeholders, you continue the education, and then you actually start to get some interim data. And so that's where we're at. This is what our study is. It's a prospective randomized clinical trial, single center, and it's basically looking at patients that come into the ED with undifferentiated abdominal pain. You think they've got appendicitis, you think they've got gastritis, you think they've got cholangitis, you think that they've got diverticulitis, you're not really sure, it's undifferentiated, you think they've got SBO, they come into the study. So far, we've enrolled almost 150 people into the study. The interesting thing for our primary outcome, what we wanted to see was we wanted to make sure that people who were not getting the oral contrast were not getting rescanned, right? That would be the last thing that we'd want. Everybody had to give informed consent to do it. So far to date, none of the patients who did not have the oral contrast had to be rescanned. It's just kind of awesome. We're pretty excited about that. We had some stopping measures from the IRB in case that did happen, but so far that did not happen. And this is some of the early data that we have out right now. So this is the data in terms of length of stay. So folks who did not have to have the oral contrast, those are the folks on the left side of the screen there, they got IV only. Their length of stay in the emergency department was approximately an hour and a half less. We looked at time to diagnosis. Think about that 22-year-old kid who comes in with that right lower quadrant abdominal pain, right? The last thing he wants is to be sitting in the ED any longer than he actually needs to be. Our time to diagnosis is approximately cut by 1 hour for folks who did not have to drink the oral contrast. So getting back to the 17 years, I think part of like ways to kind of chisel into this is to do projects like this at your institution. It's ways to kind of like elevate your institution. Now maybe at your shop, you're already kind of not using oral contrast, and you guys have been really smart about that. But I bet there is an initiative that you guys are kind of passionate about. Look, identify stakeholders, use this knowledge to action cycle, and particularly like use your residents if they're available as well. And that's it. Thank you. Yeah. I have about 5 minutes if anyone has any questions.
Well, I definitely appreciate you talking about the barriers. Because I think when a lot of these ideas come up, I think that we're passionate about it, we understand the literature. To us, it's just what's right and what should happen. And we're surprised sometimes when that happens to run into these obstacles. So I think you shared a nice way to engage the other stakeholders and, and as you said, not try to just ram it down their throat, but make sure you have the right people on board. So.
Yeah, that was a big part of this initiative. Initially when we talked about this, we decided, you know what, let's not even do a study. Let's just change. Let's just change our institutional policy, since this is what providers want, and this is what the literature supports. And we got a lot of pushback. We got a lot of pushback because we realized that it's not just our department. Yeah, it's called the emergency department, but we've got GI docs, we've got surgeons, we've got radiologists that are there. And so we tried to do it unilaterally, and it was not a good idea. And it was actually really nice to kind of step back a little bit and then identify those other stakeholders and bring them in and say, how can we do this together as a large institution? So kind of learned that the hard way from this one.
How long do you think it took from inception of the idea, we want to go ahead and try to do this project, to now you're in the middle of doing the study?
Yeah, that's a good question. Probably it took about a year. It took about a year to kind of get it through the IRB. The writing of the proposal wasn't that hard, but putting it through our institutional board review was really challenging because we were kind of doing something that was against the standard of care. Our institution says that if you're going to get a CT for undifferentiated abdominal pain, you should have oral contrast. And that had never been done before. They've done it for appendicitis. You just feel like the patient has appendicitis, but it had never been done before for other undifferentiated abdominal pain. And so we really needed to reassure our stakeholders and our IRB that this was safe and this was going to be really safe for our patients. And so initially when we submitted it, we didn't have any stopping measures for when we were going to stop for if patients got repeat CTs. So our IRB gave us that feedback and we amended it. That was probably the most challenging part. All right, well, thank you very much, everybody. Have a great day.